Hi, my name's Tom DeCanto. I'm a sports podiatrist and an elite distance runner. And today we're going to be talking about a tricky condition, sesamoiditis. And you're listening on the Physical Performance Show.
Tom DeCanto, welcome to the Physical Performance Show. This one's been a long time coming.
Thanks for having me, Brad. Yeah, we finally got to tee it up, so that's good.
Organising between two relatively busy practitioners is not always easy. But Tom, we do appreciate not only your clinical expertise as a very accomplished sports podiatrist, but obviously the marriage of your professional work with also your elite running status is a rare blend, and one that definitely the running community respects and benefits from and appreciates, aka the running shoe geek, over with our friends at Inside Running, who many people may know you from. But Tom, we've brought you on today with the sole intention of diving into what we call a tricky condition, and that is this condition known as sesamoiditis. So many people will have heard of that. Some will have experienced it. But Tom, can you start by just outlining what sesamoiditis even is in terms of a diagnosis?
The first thing I think is funny is that even the way it's pronounced is probably different. Like I call it sesamoiditis. I know you're saying it differently, so who knows how you actually say it. But yeah, so I tend to see these. It's relatively common, I guess, for a podiatrist, and often we're not the first port of call. Like I actually see it a fair bit from referrals, maybe from physios that have sort of, it's just a bit of a tricky case that hasn't sort of resolved with time and with standard care. But yeah, essentially the sesamoids are just small round bones. I think sesamoid is from maybe Latin or Arabic for sesame seed. And they're literally just these small round bones. And when we talk about sesamoiditis or sesamoid pain, it's generally the ones that are underneath the big toe joint. But even the like the patella, the kneecap is I guess also a sesamoid. And actually, I like to use the knee joint as a good analogy for a lot of people coming in with sesamoid pain when I'm discussing management, because there's actually a lot of crossover with how you might manage anterior knee pain and sesamoid pain. But yeah, essentially those two bones are sort of underneath. They're weight bearing. They sort of distribute the weight over the first metatarsal head, the big toe joint on the forefoot, and they lie within these tendons, flexor tendons, so that the big toe joint has two flexor tendons, and the medial and lateral sesamoids. These two sesamoids lie within those tendons. And the job is to improve the mechanical efficiency of that joint. So the sesamoids kind of improve the leverage and lever arm for the muscle to exert force. A bit like the quadriceps and the knee can sort of help with the knee joint as well.
So they can confer a mechanical advantage to the all-important big toe. And Tom, how would you describe the importance of the big toe to the endurance sports community, the running population?
Yeah, I mean, I think it's really important. We call so there's there's two main ways people can propel off their foot. We call it high gear and low gear. And so high gear is when people push off through big toe, second toe, and so they're pushing off through that medial forefoot. And then you have some people that sort of propel a little bit more low gear, and low gear would be sort of like that axis off second through fifth, a little bit more laterally. And, being the human body is pretty good to actually adapt. So there are some people that have probably always loaded a little bit more laterally than others, and probably those lateral metatarsals are a little bit bigger. So it's more of an issue where people, if they have an injury issue where or wearing a shoe or something that puts off their usual mechanics and shifts them to what their body's not used to. But ideally, I guess, when you're thinking about like ideal mechanics, you kind of would want people to be propelling more off that high gear, that big toe joint, for like reasons of like mechanical efficiency. And this whole thing called like the windlass mechanism, which is where the flexor tendons and the plantar fascia wrap around. When the big toe joint extends, it kind of creates an arch raising position of the foot. So if you're propelling off through the big toe and if that big toe extends nicely, then you kind of get this passive stability mechanism happening through the arch of the foot as those the fascia and tendons wrap around the big toe joint. It kind of creates this arch raising. So the foot kind of resupinates passively via that mechanism in push off, which you kind of want. You want the foot to pronate and then you want it to resupinate. And pushing off the big toe joint can help with that.
So it's critical. Just out of curiosity, Tom, you mentioned the two types of runner, if you like, the low gear and the high gear there, depending on which part of their foot they propel from, either laterally or more medially across that first and second toe. You're determining that through like gait analysis. Is that right? Video gait analysis?
Yeah, so combination things. It will start with just looking at callus patterns. So the first thing when I get them up on the bench, I'll look at the plantar surface of the foot, and often I can tell where they're propelling just from the callus pattern. And then I'll look at their footwear wear pattern. So then they'll have their running shoes in here. I'll look at the wear pattern. So I like them to bring in some shoes with a bit of wear. And then I'll do the visual gait assessment. So the combination of those three things, it just sort of all confirms kind of what I'm seeing. And often it'll all just make sense once you sort of go through that process.
Oh, that makes sense. Thank you, Tom. So we know the big toe is important, and that as you outline the anatomy there, there's those two tendons that come down, and essentially the sesamoids live in those two tendons, the flexor hallucis brevis. But in between those, I think it's worth pointing out, isn't it? There's that big flexor hallucis longus tendon that goes between them almost like a river, which I know in clinical experience often see quite a degree of weakness in that flexor hallucis longus tendon that lives between those two sesamoids. Anything you just add on the flexor hallucis longus muscle and its contribution to running and importance of foot conditions?
Yeah, it's probably it might be under considered. Like I think it's pretty important. It's a relatively large muscle belly up behind the calf there, and obviously with that long tendon. Often you can assess it by trying to isolate certain positions with the big toe joint flexion. And so, for example, if someone does have sesamoid-related pain and they've got poor flexor strength, whether that's longus or brevis, that would be a really good strategy to try and strengthen them. Often I don't know whether it's because I'm not seeing it or not. Or whether it's just reality is it doesn't happen often, but I don't often see the longus being symptomatic around the actual in between the sesamoids. I often see that more either just distal to it, like up as it inserts into the distal phalanx, the tip of the toe, or more around the ankle. It seems to be relatively well protected in that position there. I think maybe a couple of times I've seen maybe like symptomatic right around the sesamoids where it was the differential for sesamoid pain.
So Tom, with the sesamoiditis, it's a tricky condition. You used the word yourself at the start, in that there's so many subcategories, if you like, of sesamoid pain or sesamoid pain. Can you just outline the different categories, if you like, or different presentations around pain generated from these two little bones under the big toe?
Yeah, I kind of try and do it as a diagnosis of elimination. So I firstly want to eliminate any of the serious pathologies that can occur around the sesamoids, and so that would be like a stress fracture would be the main one. There'd be like either an acute fracture where normally you have more suspicion because the history is like a high impact sort of thing with acute pain and swelling, but you can get these more insidious onset chronic type stress fractures that you need to differentiate from just the other causes of pain there. So I'd be going through the history like with any injury, like you get all the clues from the history, and then the physical exam to try and sort of determine, how sensitive it is on direct palpation on the actual sesamoid, and just some other clinical tests that you might do to differentiate. But if I have any suspicion of bone involvement, I'll likely refer for X-rays and MR, just to rule it out, basically. Then once it's ruled out, I'd be more happy to treat more conservatively and like one of the other conditions, which like I think most commonly when I think of sesamoiditis, I think of joint pain. So I just think about the little sesamoid running through the groove in the plantar aspect of the first metatarsal head. And often I think there's pain associated with that joint. So again, it's similar to patellofemoral pain in the knee joint. So there's just sort of like the contact pressure. The difference being, though, with the sesamoid, it's unique in the fact that it's also hugely weight bearing. The compressive loads are high as well as the tensile loads, and so that's why it is a tricky condition, because it is it's on the foot, and there's a lot of load that can go through them. So once they are irritated, we may need to be quite aggressive with offloading them to let or changing the position of the joint to sort of alter the contact forces around the sesamoid and the first metatarsal head. There's obviously other conditions, like one I've seen a couple of times recently is the bipartite sesamoid. So it's just the sesamoid as it ossifies in kids, the growth centers. Occasionally, instead of just becoming one bone, it becomes two and occasionally three pieces of bone. And to need to differentiate that between just an anatomical variant versus a stress fracture, which you can normally do from the history and the X-ray. But that can be really tricky, because the bipartite sesamoid will have this fibrous connection, and sometimes that fibrous connection can get symptomatic and disrupted. And so it is a little bit like a stress fracture, in that these two halves that were once connected by this fibrocartilage kind of inflamed and irritated and need to be settled. And I think of it again a bit like another analogy for another injury I see a lot of is the Navicular Syndrome. So that's where there's like the type 2 Navicular Syndrome is like where there's the accessory bone. So that the medial side of the navicular has an accessory, and it's not attached to the main body by bone. It's the fibrocartilage again, and so people with navicular syndrome are more likely to develop that if they have that fibrocartilage connection with their accessory navicular. And so I think people with bipartite sesamoid, they might be possibly more inclined to having that pain there due to the anatomy.
And the prevalence of that bipartite presentation, or as you say, rather than it being one bone, it can be two bones or three parts, is quite prevalent in preparing for today. It's been reported at around 30% of individuals, and of those, 20% will have it on both sides. So it's not common.
No, that's right. Yeah, it's relatively common. Yeah.
So there's quite a few things that can occur in terms of sub-diagnoses, if you like, of sesamoid or sesamoid pain. I like the analogy, though, Tom, that you think of it in terms of it's a joint-related pain. This is a joint, and anyone that's battled with kneecap pain or patellofemoral pain knows that can be, I'm a lifelong sufferer on and off of patellofemoral pain. And so there's this multitude of factors to be considered in trying to calm that down and also, restore people to their desired activity levels. Obviously, as you said, even in many ways more tricky with this condition because of the high forces, including body weight, every time we toe off. You mentioned two terms there, compressive and tensile loads on the structure, Tom. Just to help those that may not have heard those terms, what do you mean by those?
So compression is just that direct force from the ground pushing up onto the foot. So it's just this compressive or squashing sort of load that you'll get. And then tensile being, so you can think about the tendon stretching. So those sesamoids lie within the flexor, the brevis tendon, the big toe flexor tendon. And so when I would say that sesamoid would be under more load as well when that tendon is under more stretch, or that more tensile load, which is stretching, which you typically get just at that moment of heel off in the push off phase. You get that most sort of that tensile stress. And often you'll ask people about, even when they're in a clinic walking or running, you can ask them, at what point are you feeling most of the pain? And often it is in that push off phase, and they're just about to, when the heel just comes off and they're getting into that push off phase, and you'll have most tensile load there then. The compressive load comes just slightly after that, but it does go hand in hand.
Yeah, okay, great. Before we shift to the presentation of this condition and then the management, Tom, putting you on the spot here, but are there any metrics that you tend to educate your runners and patients around with regards to forces that the big toe deals with in terms of metrics of body weight or anything like that?
In terms of how they can measure how much force is going through there, or
just from any studies in the field that may have been done around the mechanics of the big toe for propulsion, contribution, or multiples of body weight that it deals with at various running speeds?
Yeah, no, I'm not sure of any studies, to be honest, of the actual loads going through first. But yeah, you could be pretty certain it's multiples, 5, 10 possibly times body weight load going through that if they are propelling off through high gear. Yeah, for sure. It's high loading.
Yeah, which I mean inherently makes sense, doesn't it? Tom, someone walks into the clinic with this, what things, so for the listener tuning in, possibly, I should say, quite rare though, that if they're listening, they're like diagnosing their sesamoid pain during this podcast would be quite a first. But what things do people present with this condition, Tom?
It's normally very localized pain. So the pain is directly under the ball of the foot, the big toe joint, on the plantar aspect. So there's never pain on top of the joint unless they are also having another condition as well. So the sesamoid pain is always on the underside of the foot, normally quite localized. They can get co-presentations often, especially if it's been acutely overloaded through training or other changes. There can be swelling, like visible swelling, and it can be quite painful just to put any weight at all through there. And it's like fat pad swelling or bursitis that can happen just underneath the sesamoids. So you could feel or see some swelling there, but there doesn't have to be any swelling to have sesamoid pain or sesamoiditis. So they're the main things. Obviously, pain in push off, as mentioned before. So it's this pain on if you try to do a single leg calf raise barefoot on a hard floor. You'd have, if you've got a sesamoiditis condition, you'd be quite irritated right locally in that area around the underneath the big toe joint. So
localized pain in the area of concern, swelling at times. I've certainly had one bout of this last year after a bucket list cycling race, the Grafton Varel 228 Ks with 3,000 meters of climbing, and I finished the race. I could feel pain in that area, and my toe was huge underneath near my sesamoid, sorry. And I actually was very worried. I thought maybe I'd somehow fractured it, which would be unlikely, but I was stressed because it was the size of almost half a golf ball. So I think it's probably pointing out this can be super swollen at times. And then pain with push off, like you said, Tom, in terms of like imaging, what imaging might you incorporate to help? You've already mentioned MRI and plain films, but the use of those, when would you decide to do one and not the other, or a combination?
I'd often do both together. If I'm going to do one, I might do both, because occasionally there'll be something on the MRI where it's not, the actual bone anatomy is not as clear as I'd like. And so you get a little bit of information from the X-ray. But the X-ray can't give you the information that you want from the MRI, which would be like any staging, any bone stress. So you won't know if you could see a plain fracture, but you won't know the level of how old that fracture is or how active that fracture is, which would be indicated by the level of swelling in the actual bone, which we'd see on MRI. Occasionally there's been some that I'd refer to their GP to go see a sports doc who may want to get a CT. So just a little bit more detail around the bony anatomy, and just checking for any small cracks that might not be seen on both MRI or X-ray. So that would be the third layer of imaging, I'd say would be a CT if things aren't just tracking well with normal treatment.
And with the bone stress side of things, obviously there's the stress fracture presentation, but then like any other bone in the kinetic chain or the skeleton, that's a common site for running-related bone stress injuries, there's also that possibility that there's like stress response in the sesamoid, correct?
Yeah, definitely. Yep.
Which would require an MRI, like you mentioned, to determine.
Yeah, and then you could sort of then guide on back to run how long that might be off for, how aggressive you'd want to try and offload it if there's bone swelling.
And so the management of this condition, Tom, you use the word offloading several times. That I think is fairly inherent that people need to change their load in. Any guidelines or suggestions there, or is it all based on clinical presentation in the clinic with you, their degree of symptom irritability, and of course their diagnosis? But how do you navigate that with the running athlete, for example?
Yeah. So it's all that. It's all that you mentioned. So just got to figure out the diagnosis and the severity, and then thinking about the load. So often if they're symptomatic, I want to reduce some load, and we can obviously do that by manipulating their training and figuring out, what their training looks like. And if it's something that they can train through, then modifying mostly intensity and hills. So taking out some of the faster running where they'd be more up onto the forefoot, and hills where they might also be loading the forefoot more. Often they need to stop running completely for a period of time, but if I can offload locally via mechanical means, that means they might be able to get back quicker or train through to some extent and keep jogging a little bit. So to then reduce the load mechanically, it's thinking things like footwear and padding, strapping, and orthoses. So that's kind of the approach I would take.
So footwear, padding, and strapping, taping. There were some great tips there about return to run, obviously reducing the workload, but being mindful of running hills and decreasing intensity work to get off the forefoot a little. With footwear, Tom, obviously this is something you're deeply passionate and knowledgeable about. What strategies can the sufferer of this condition consider in terms of footwear choices?
We're pretty lucky now, because essentially what you're looking for is a maximalist type shoe. And so you're looking for a shoe that's high stack, so has a lot of cushioning, and potentially has a stiffening element into it. So something like a carbon plate, which will increase the bending stiffness, which would then require less extension of the big toe in push-off, which would then reduce tensile stress. And the cushion in a maximalist type shoe will reduce the compressive stress. And so there's lots of options now, and I would base my recommendation off their biomechanics. And so if they've got the other issue would be, so that offloads well, kind of thinking about the sagittal plane. So thinking about the bending stiffness of the shoe, the forefoot rocker design, allowing that forward transition and push-off phase to be quite efficient and reduce load to the sesamoid. But you got to consider, I guess, with a maximalist type shoe, they're higher off the ground and they can be a little bit more inherently unstable in the frontal plane. So that's the side-to-side plane, so supination or pronation. And so if someone also has quite a pronated foot function and they might be sort of really rolling across onto that big toe joint, I'd want to make sure that maximalist type shoe is also not too unstable. So there are some models that are more stable than others. And so then I'd be more recommending for those people that have that foot that really kind of rolls in a lot aggressively across the big toe joint. Just a more stable model. So it might be the difference between some of the newer ones using the really soft foams, like more of the foams that are used in the racing product. Instead of using that, it might be just more of the training models, the EVAs that aren't as soft. So you want cushioning, but you don't necessarily want something that's so marshmallow soft that it decreases the stability in the frontal plane, the side to side. There's a bit there to consider, but mainly you're basically just trying to get more shoe on the foot and make sure it's not too unstable.
That's a brilliant summary. Get more shoe on the foot, but being mindful of the stability of the shoe, as you mentioned, Tom. Sometimes the higher stack shoes typically have more motion in that side-to-side plane for keeping it simple in terms of people's understanding.
Yeah.
The rocket, just to pull it apart a little bit if we can, Tom, the rocker bottom design in shoes, obviously this is more prevalent now in the shoe market. How can that can that have a negative or positive effect on this, or it depends?
I would say generally positive. So the rocker will allow the shoe to sort of help you with that propulsive phase without the big toe joint having to extend as much. And it's different to toe spring. So traditionally in lower profile shoes, you'd have a thing called a toe spring where the forefoot kind of bends upwards, and that's just more to do with the shape. It's not really a true rocker design. To do a proper rocker to offload the sesamoid in the joint, it needs to be a high stack shoe, and the midsole needs to properly taper into the toes where it just gets thinner. But the actual plane of where the foot sits is relatively flat. So the big toe is not necessarily preloaded into extension. It's just sitting on a flat bed, and the rocker is more to do with the geometry of the midsole tapering from the underside. And that generally works really well, that rocker design, because then, especially with a stiffening element like a carbon plate, it just helps with that forward propulsion without the big toe joint having to extend. And the more the big toe joint extends, the more load there are, compressive loads and tensile through the sesamoid.
So increasing the bending stiffness of the shoe, however that's achieved, is generally a good principle here.
Yeah. So even having a thicker soled shoe, it will increase the bending stiffness. But then when you add stiffening elements like carbon plates, that'll take it to the next level. Whereas if you have like a very thin shoe, like for example, traditional racing flats that runners used to run in, like they were just so flexible through the forefoot. And even when we went through a bit more of a minimal phase through footwear, and more brands are bringing out more minimal type shoes, they were very flexible. But as soon as you go to a more standard type shoe, there's more inherent stiffness just because there's more foam.
Yeah. Okay. Some great points there, Tom. So there's some offloading strategies, footwear choices that can modify load in, and podiatrists, sports podiatrists, you're so well versed to also make some modifications inside the shoe. What strategies can you deploy there?
Often simply either modifying the original sock liner that the shoe comes with felt, or often I'll use a good prefab orthotic, so an orthotic that is off the shelf, that if it matches the foot relatively well, it can be easily modified, and modifying it would involve both reducing compression and tension. You can do that you can reduce the compression by doing a pad that extends into the forefoot but has like a cutaway or a deflection sub first. So underneath that first, it's almost like it's got a little cavity to sit in, and we try and then shift more of that weight-bearing pressure around the sesamoids to like second, third, fourth, fifth, and just behind the sesamoids into the distal arch of the foot. And then you can use a thing called a metatarsal dome, and a metatarsal dome is just like this, a dome that essentially sits just behind the forefoot. That can take maybe a little bit of load off the sesamoids. And then the main thing is good contour through the arch can often take some load off. Contact load. So if the arch is taking a bit more weight, then it's just a pressure redistribution thing. So if the arch is now weight bearing, which when it once wasn't, it's taking some of that weight, as well as if that arch profile is stabilizing the foot from rolling in a little bit more than it was without it, you may reduce a little bit of that tensile pulling stress, because every time the arch sort of flattens and lowers, you get a little bit more tension through those tendons and the sesamoids, and that may help as well. So a little bit of mostly pressure redistribution, and maybe a little bit of reducing tensile stress through supporting the arch. Yeah, and often with footwear or with these orthotic insole modifications, it's all about just reducing load to get symptoms down, maybe help them to, if it's at a level they can train through a little bit, then that's great. Or it's just going to allow them to get back running maybe a little bit sooner, maybe allow them to do rehab a little bit easier. And then my goal is always to, at some point, once we've addressed other issues, if there's strength deficits or the shoes with an issue with the shoes, then they can eventually they won't require that sort of extra offloading. Like it's not going to be a lifelong thing they need because of some structural thing. Often they're injured because of a training load error, or all of a sudden wearing a shoe that their foot wasn't ready to use. And there's obviously some of those cases where really chronic, like, this is one of those conditions where occasionally you'll get someone with sesamoid pain for 3 years, for example, and they're more someone where they might need to be managed with an orthotic long term, because they just find that every time they don't wear it, they just have more symptoms and more issues. So we there's going to be a subcategory of people where we've got to be more mindful with ongoing protection, but that's a very small, I would say that's, a very small percentage of people with sesamoid pain. Often it's just deload, let it recover, and then gradually they can get back to not using orthotics and not being too worried about the footwear that they're using. Which,
Tom, overlaps with the share-ins of your UK-based sports podiatrist colleague, Ian Griffiths, who, came onto the show to debunk some of the myths around orthoses use in sports. And one of those is that they're not typically or necessarily a lifelong sentence, but there are some that will benefit from, ongoing use of, it's essentially just a bit of sporting equipment, a device, right? And orthosis is just a device. Tom, that's brilliant what you've just shared there. It's about pressure redistribution and potentially supporting the arch to decrease tensile loading. Tom, for those that don't come right with these strategies, and they, as you know as well as I do, that these patients, these runners exist, these athletes, at what point would further surgical consideration be indicated?
I guess generally, I guess it would come on the diagnosis. So if there's a really problematic fracture or bipartite that's taking a long time, then I'd be more likely to get them into the surgeon sooner for opinion. Or if it's just a really drawn out sesamoiditis case that's just 6+ months where they've actually tried all the stuff that they should have tried, then I always say it's there's no harm in going and having the consultation. It doesn't mean they're getting surgery. It just means they're having that conversation with the surgeon. What do they think? If there was a procedure, what's the procedure? What are the pros and cons? So at least they just have that information. Doesn't mean they have to get the surgery, but they've got an idea of, if this still continues to not improve, what other options are there?
Yeah, and sometimes it can be reassuring to be told that they're not a candidate for surgery, right? Because it can be an ongoing process, the rehabilitation efforts, and sometimes it's nice to have already covered that and been told that, right, you've got to focus on this and be patient with it, because I find this is a condition that requires a lot of patience and adherence to the work.
Yeah, definitely.
Any tips, lastly, Tom, on the strength and conditioning side of things, apart from the obvious, it needs to be graduated and progressively increased in its demand? Any tips that you've sort of picked up over your years?
So I'm very sensitive to, so this will link in with strength, but I'll start with footwear again. So I'm very sensitive to the fit. So before I assess function of shoes, like in recent years, I am trying to be very, strict with just every single runner that comes in, or anyone, like assessing the fit of the shoe and making sure that they have appropriate toe box space. Because for a lot of forefoot pathology, I think a big contributing factor could just be that they don't have enough space in their shoe. Could be length, could be width, could be the too much tapering. Even a lot of running shoes are too tapered in the toe box. And if they got a relatively squared off or broad foot and it not allowing for much toe splay, I think that could increase their risk. So firstly, checking the fit before function and making sure, because I've had some easy wins in the past where they've had sesamoid pain, and you need to size up, and you need a shoe with, you feel like there's slightly more wriggle room, so maybe a little bit broader through the toe box. And I've had really good results by just getting a better fit. But then once they've got that, or if that's not the issue, then still wanting to facilitate, like an exercise that you can do at the very beginning, it's not going to irritate it, is like a seated intrinsic exercise. And one of my favorites is just, which I also give to people with bunions, is just activating the abductor hallucis, which is just the muscle in the arch of the foot when contracted, the big toe moves out away from second. So that movement can, I think, for some people help with better weight transfer through the sesamoids and push off. So often people with sesamoid pain, they don't even know how to do it. So I ask them to do it. I show them on my foot, the big toe is sort of moving away, and because they've never tried to do that movement before, their brain is not really connected to that muscle, and they don't even know that they can do it. So once they can actually get the motor control to actually do that exercise, to get that big toe to splay and move away from second, I think that can be quite helpful and an easy win, because it's not going to really put any mechanical stress on the sesamoid. It's not going to increase symptoms, but that can really alter the loading that goes through in function if they've then got the ability to feel what it feels like to have toe splay, to get that big toe to move away from second. It could alter the contact forces through the sesamoids as they're pushing off, if they can start to get a little bit more of that splay then in function. And often I'll do, in conjunction with the exercises, is maybe some strapping to help when they're in function to get that splaying happening, to get the big toe away from second. Sometimes a toe spacer, but the strapping works quite well along with that exercise. And then the other main one would be, again, relatively low risk for irritation, is the seated just toe flexion exercise. So just getting them to really, you can go relatively hard, like get quite a heavy resistance TheraBand and put a lot of tension through it, and then get them to really push down. Pain limiting, but if they can do it relatively pain-free, then I just get them to really work on isolated toe flexor strength before they graduated to any sort of weight-bearing exercises.
Yeah, because that return to weight-bearing, standing calf raise as an example, can be at times quite provocative and quite a dance.
Yeah, definitely. So often when getting back to the weight-bearing exercises, they're in that protective setup. So they're in the shoe with the really well-cushioned shoe. Maybe with an orthotic or the deflections or whatever as well. So it takes a lot of that compressive load off, and they can do the strength without it really re-irritating it too much.
Yeah, no, brilliant. And Tom, on these tricky condition episodes of the show, we don't typically get a physical challenge for the week, but I think that abductor hallucis exercise might be a nice physical challenge. So we must get a photo we'll pop it up on Instagram of you demonstrating that exercise, and we can all try that.
Yeah, sounds good. Yeah, keen. Yeah,
a video, I should say, not a photo. Tom, thank you for your generosity in sharing your expertise around this one condition of the many that you treat routinely in your professional life. For those that want to engage with you further on this, find out more about you and your services, where can they go?
So I've just my business name's just changed. So I've been Walker Street Sports Podiatry for 6 years now. I'm Pinnacle Sports Podiatry. So you can find me. I don't think I'm on Facebook or anywhere else, but I'm on Instagram. So it's just Pinnacle Sports Podiatry, and also my own account is just Thomas Docanto. So yeah, that's if people want to find me, they can find me there.
And you'll be taking to the streets again with your running career. Prior to recording, you mentioned hopefully before the year's out, we'll see you back and back to your best, aka your second place at the Melbourne Marathon return after COVID. There with what was your finish time there for that one, Tom?
2:14:40.
2:14:40. So, mate, you really practice what you preach and do it with such fine style. So we wish you all the best for the competitive side of things for the year ahead as well.
Thanks, Brad. Cheers.